All right, we're going to talk about the digestive system. And clearly, we are not treating people directly for digestive system disorders, but their digestive system status is certainly going to affect their therapy status and their healing. So we'll just talk about basically the functions of the digestive system, the parts of the digestive system, and then some different disorders which may affect therapy. And then we'll have a second section where we'll talk about basic nutrition and then the nutrition that needs to be in place for healing, which is what we're always dealing with. Not always, but a lot of times. So, basic terminology associated with digestive system conditions, basic symptoms we'll talk about, the medical diagnosis of digestive disorders, common signs and symptoms, risk factors, etiology, pathogenesis, all the stuff we usually talk about of major gastrointestinal conditions, medical, surgical, and therapy interventions, use of pharmacological management, and how to recognize in acute digestive conditions and what is the appropriate response to an acute condition. So the digestive system is basically a long tube with some accessory organs. And its job is to ingest food and fluids, break them down into their units, um, and absorb the necessary components and get rid of what we don't need, our waste products. So there's a mechanical and a chemical digestion of food. So in the mouth, we start with both, chewing just to mechanically break up the food and then exposing it to saliva, which has some enzymes in it to help start digesting it. The esophagus is basically just transit from the mouth to the stomach, with sphincters entering the stomach to keep the stuff from coming back up. And the stomach is going to mix and dilute the partially mechanically processed and chemically processed food. And it's also going to secrete enzyme to digest protein. It's going to add intrinsic factor to help process vitamin B12. It's a very acidic environment because some of the cells in the stomach produce hydrochloric acid because we need those strong acids to dissolve the foods that we're eating into a form that we can then ingest the nutrients. So once it goes from the stomach to the small intestine, you get the joining of enzymes from the pancreas. Pancreas provides a lot of enzymes in its exocrine function to help digest food, and bile from the liver, which is stored in the gallbladder and then injected into the common bile duct, which goes into the small intestine. And bile emulsifies as fat, and the pancreatic enzymes digest fat, protein, and carbohydrates. Most of the absorption of nutrients happens in the small intestine, and the small intestine has a very convoluted inner surface for lots of surface area for absorption, where the nutrients get absorbed into the bloodstream and then they get distributed to wherever they need to go. Some of them go to the liver for further processing because the liver is sort of our chemical factory, and we'll talk about the liver as well. Um, the colon, the large intestine, absorbs water and electrolytes that are left over in the fluid that's traveling through our digestive system. And it stores anything we're going to get rid of in the rectum until you're ready to get rid of it. So basically, you break the food down, you chemically and mechanically, you absorb what you need, and you get rid of what you don't need. Easy, right? As long as it works. When it doesn't work, that's when things get crazy. So the key components go from the mouth to the anus. They're all involved. There's the smooth muscles along the digestive tract are controlled by the autonomic nervous system. Peristalsis is the movement of those smooth muscles that moves the food and waste through the tract. The digestive structures the accessory organs, if you want to think of them that way, produce substances that aid in the digestion and the nutrient extraction. So the gastrointestinal conditions are that are most relevant to PTA practice are the ones that we are going to focus on. Certainly, there are lots of other ones. Understanding GI conditions is important is because they can significantly impact patient mobility, exercise tolerance, and treatment planning. So, general symptoms of any kind of GI disorder, you can have abdominal or chest pain. And so, what else can chest pain be? It can be cardiac related, and so that's worrying, right? As long as they have been cleared for cardiac. Um, Heartburn, bloating, nausea and vomiting, changes in bowel habits. Sounds like a Pepto-Bismol commercial, but there you go. Those could be a lot of different signs. Serious warning signs include blood where there's not supposed to be blood, blood in your stool, or vomiting blood. Neither one of those are good. Severe abdominal pain, persistent vomiting, or significant weight loss. And significant weight loss when you're not trying to lose weight is really the thing. So there are a lot of different ways that they're going to diagnose GI disorders. The initial assessment is usually done by signs and symptoms and physical examination and a pain assessment, assessing the location, type, and severity of pain, and a history of your bowel habits. The advanced diagnostics, sometimes they can make a determination just based on the clinical assessment, but sometimes then they will go to an X-ray or a CT scan. Sometimes ultrasound imaging as well, even though that's not on this list, but or MRI imaging. Ultrasound is significantly less expensive than MRI and CT scan, and so I don't know why they don't do it first because a lot of things can be found out on ultrasound imaging, but my opinion only. An upper endoscopy is where they put a scope in the upper part of your digestive system, and a colonoscopy is where they put a scope through the lower part of your digestive system. And then, of course, laboratory studies may or may not reveal what's going on with your GI disorder, and a biopsy um, if they suspect cancer or other tissue signs. So biopsies can be done during an endoscopy or a colonoscopy, so that's one less procedure you have to undergo, which is good. And when you go in, now the recommendation for your first colonoscopy is age 45. They used to say 50, but apparently colon cancer is more common. It's becoming more common in younger people, so they want to screen as soon as possible. Because if you get it early, there's a much better chance for curing it. So if they find polyps or anything like that, they will excise them during the procedure. Same thing for an endoscopy. And then they will send those to the lab to look at the tissues and see what's going on. And a lot of times they'll just say, well, it's just normal tissue. And sometimes they'll say, uh-oh, there are dysplastic cells that might be precancerous or maybe even cancerous. So GERD, gastroesophageal reflux disease, is where the stomach contents backs up into the esophagus due to a weak esophageal sphincter. So normally we have that sphincter between the esophagus and the stomach to keep things from backing up and keep them moving forward. Well, risk factors include obesity, pregnancy, hiatal hernia, which is where the stomach comes out, the top of the stomach comes out into the esophagus, and smoking. I don't know why smoking is, but there you go. They're smoking again. Those are risk factors for GERD. The signs and symptoms tend to be heartburn, bad breath or bad taste in your mouth, sometimes chest pain from that heartburn, breathing difficulties, and dental enamel erosion. Because remember how we said the stomach environment is very acidic because we're continuing really with the chemical breakdown of food, and that acidic stuff going up into your esophagus is bad news because it can erode the tissues in the esophagus. So some foods are considered to be making GERD worse. Greasy, spicy chocolate. I'm glad I don't have GERD. I love chocolate. And coffee. I love coffee. And peppermint, so those are all sort of almost irritants. So that's why they can worsen GERD because you already have an irritant coming up in your esophagus from the stomach acid, and now you throw in some other stuff too. So managing GERD is usually managed through lifestyle modifications. Don't lie down for 3 hours after eating. For most people's lifestyle, that's pretty doable. Avoid irritating foods if necessary, lose weight. If necessary, avoid smoke exposure. Sleeping with the head elevated, you can actually get a special GERD pillow, or you could use other. Some people just put like blocks underneath the head of their bed to raise it up a little bit so their head is elevated. Avoiding tight clothing in the abdominal area and preventing overeating. So there are medications, they're called proton pump inhibitors, and a lot of them are over the counter now. They decrease acid production in the stomach. H2 blockers reduce stomach acid. Antacids counteract stomach acid, they neutralize it. Prokinetics are to help with gastric emptying, and erythromycin helps with gastric motility, which is interesting. Sometimes they might do surgery if it's really extreme to tighten the esophageal sphincter to keep the reflux from happening. But if we have someone in the clinic who has GERD, they might not be able to do exercises lying flat. So you have to think about that. How would you modify an exercise to not lie flat? Peptic ulcer disease, an ulcer is just like an ulcer anywhere else. It's a hole in the tissue, a break in the tissue. So a peptic ulcer is a break in the inner lining of the stomach, duodenum, anywhere else in the small intestine or in the esophagus. And the primary cause, they used to think it was what you ate or how you ate or, different things, but then they discovered that there's this bacterium that's called Helicobacter pylori, and a Helicobacter pylori infection causes stomach ulcers, and treating it with the antibiotic that kills it, it's a specific antibiotic, can cure the problem. It can be caused secondarily by heavy use of non-steroidal anti-inflammatories, aspirin and ibuprofen, because those can be hard on your stomach lining. Smoking, they're smoking again. Crohn's disease, which primarily affects the small intestine, and that's an autoimmune disorder, and hepatic disorders, because the liver is involved in everything. When we talk about the liver, we'll talk more about it. So the signs and symptoms of peptic ulcer disease include burning abdominal pain, bloating, vomiting, belching, and unintended weight loss. They always used to say don't eat certain things, don't eat spicy food, don't eat whatever, but now they're saying cure that Helicobacter pylori infection, and they'll do an endoscopy with a culture and sensitivity, basically. And don't take NSAIDs and don't smoke and all that good stuff. So pancreatitis is, as the name sounds, inflammation of the pancreas. And pancreatitis can be acute or chronic. It can be caused by gallstones, or cholelithiasis is the medical name for gallstones, because the gallstones can back up, clog the common bile duct, and cause backup of the enzymes back into the pancreas. Well, the interesting thing about the pancreas is it doesn't have a capsule like a lot of the big organs. So when you get the digestive enzymes loose, it can actually digest itself, which that's not good. The other things, alcohol abuse, cystic fibrosis, trauma, hypercalcemia, hyperlipidemia, hypertriglyceridemia, or hereditary factors can all be causes for pancreatitis. Acute pancreatitis, it causes severe pain, severe upper abdominal pain. And we know the pancreas is in the left upper quadrant just above the stomach, and it can cause that severe upper abdominal pain, nausea, vomiting, and fever. On the right side of the upper abdomen is the liver, so don't get those mixed up. With chronic, sometimes it's just this chronic unexplained weight loss. They don't really have the acute symptoms. Acute pancreatitis can be pretty serious, and they will hospitalize people for that. People who have chronic pancreatitis a lot of times will need to take digestive enzymes because their pancreas is too busy being inflamed to produce the proper enzymes. And it's a dietary supplement that they take. So managing mild acute, sometimes they use a nasogastric tube feeding where they put the tube through your nose into your stomach to avoid the whole hormone cascade that causes the pancreas to secrete the enzymes. Oxygen administration, IV fluid replacement, gallbladder removal if it's caused by gallstones. And they can do the gallbladder removal laparoscopically now, where they make a tiny little incision. It used to be a big old incision, but now it's a much easier procedure, which is good. If to diagnose that someone has acute or chronic pancreatitis, for acute, they'll see elevated enzymes. So amylase is a pancreatic enzyme that dissolves starches, basically, and lipase is a pancreatic enzyme which dissolves fats. And in chronic pancreatitis, the enzymes are going to be normal, but they'll see changes in the pancreas in imaging. So severe acute pancreatitis could put you in the ICU. It's a very serious thing. Feeding tubes, breathing tubes, IV fluids, they're monitoring you for hypovolemic shock, where your blood volume goes down, your blood pressure plunges, and they're managing you for organ failure. So it's pretty serious. It could kill you. It's not a good thing. Um, Alcohol cessation is essential for all patients, a minimum of 6 months, and indefinite if it's a chronic issue. So you think about I don't know, how often do you think about your pancreas? Maybe not that often, but it's pretty serious. So something that can kill you. Pancreatic cancer is also one of the most deadly forms of cancer, one with the least percentage survival rate, and it's very quickly progressing. So your pancreas is very important. There you go. Peritonitis, the peritoneum is the lining of the abdominal cavity, and peritonitis is inflammation or really infection of the peritoneum. So it's mostly caused by infectious agents, bacteria, viruses, and fungi. And if your bowel is perforated, like in an accident or in a surgery, or your appendix ruptures, liver cirrhosis can cause peritonitis, and peritoneal dialysis can the peritoneum can get infected. When we talk about the renal kidney system, we'll talk about peritoneal dialysis. But it's super, super serious. This is one of the top 10 things that could kill you. The symptoms are severe abdominal pain, high fever, abdominal swelling, puts you in the ICU on IV antibiotics and possible surgery. It is very, very serious. Appendicitis is inflammation of the appendix, a lot of times caused by a blockage of either mucus or stool. And the bacteria can just get in that little thing and multiply and cause all sorts of problems. The symptoms are lower right quadrant pain, loss of appetite, nausea, and vomiting. Tenderness, there's a particular type of tenderness that they call rebound tenderness that they will assess you for if they think you have appendicitis, where basically they push down and it doesn't hurt as much on the pushing down, but then when they let go, that's the rebound tenderness. Emergency surgery is the treatment. They remove that appendix and off you go. So hopefully, hopefully, inflammatory bowel disease is an umbrella term for several different disorders. There are two major types, Crohn's disease, and now they took away all my apostrophe S's, even though you'll still see it a lot of places, and they call it Crohn disease. And ulcerative colitis, both are chronic, incurable conditions, but they can be treated. It's chronic irritation of the digestive tract lining, and they diagnose via colonoscopy. Usually there are remissions, but neither one is curable. The common symptoms are abdominal pain, diarrhea, nausea, bowel urgency, fatigue, weight loss, and anemia. The risk factors could be environmental factors, immune system dysfunction, bacterial factors, or genetic susceptibility. Crohn's disease is an autoimmune disorder, so immune system dysfunction, and it mostly affects the small intestine, whereas ulcerative colitis mostly affects the large intestine. Neither one is any fun. And they use, because there's an immune system factor, they use immunosuppressant drugs to treat Crohn's and ulcerative colitis. And if you watch the drug ads on TV, you'll see a million of them for these particular things. So, Crohn's disease can really be any part of the GI tract, even though it is more common in the small intestine. And they're little patches of inflammation. They're you with Crohn's disease, it's less common to see blood or mucus in the stool. It's kind of more common with ulcerative colitis, the ulcerative part being the operative term. Nausea and vomiting are more common with Crohn's and less common with ulcerative colitis. The mucosa and the muscle of the intestine are affected, and there are granulomas, which are those little fibrous nodules present. And fistulas and strictures can happen. And if you have a bowel obstruction, that's a medical emergency. It's more common in smokers, interestingly enough. I don't know why. Um, and there are some drugs that are used to treat other things, which are called 5-ASAs, and they are not usually effective for Crohn's disease. Ulcerative colitis, the 5-ASAs are effective. It's usually the large bowel and the rectum only, not the small intestine. Continuous inflammation, blood and mucus in the stool is more common than with Crohn's. Nausea and vomiting is less common than with Crohn's. And it involves the mucosa only, not the underlying muscle. And granulomas are not uncommon. So that's kind of the differential diagnosis between Crohn's and ulcerative colitis. Fistulas and strictures are also less common, and it's more common in ex-smokers and non-smokers. Isn't that weird how they're so close but so different? And those drugs are effective, and sometimes surgery can resolve ulcerative colitis in some cases, but they don't go right to surgery. So basically, they do a bowel resection where they take out the affected part and then join the two ends together. Sounds awful. Diverticular conditions. So diverticulosis. So osis is usually a condition, and itis is the inflammation. So diverticulosis means you form these diverticula, which are little small pouches in the colon wall. They're little weak areas. And then diverticulitis is when one or more of those pouches become inflamed. So epiploic appendicitis sounds fun, right? They're small fat-filled pouches along the intestinal wall. So it's sort of more like a lipoma than anything, like a little fat nodule. And it's really easy for the intestines to become twisted or lose their blood supply. And it causes severe abdominal pain, often in the left lower quadrant, which is mostly where mostly intestine down there. And it can often be mistaken for appendicitis or diverticulitis. It's generally self-limiting, but and diverticulitis is usually can be self-limiting. They usually treat it with changes in diet. So for us, our red flags are severe abdominal pain, vomiting blood, that's never good, blood in the stool, signs of shock, and fever with abdominal pain, those two things together. So we're going to monitor their exercise tolerance, and they might have a lower exercise tolerance if their nutrition is compromised because of these digestive disorders. So our assessment priorities, vital signs, and we're looking for signs of distress. We're going to assess exercise tolerance and note fatigue and energy levels. Watch for signs of dehydration, sunken around the eyes, decreased skin turgor. If you pull up the skin on the back of their hand, does it stay or does it go back to normal? Monitor nutritional status effects and assess pain levels and location. So depending on their presentation and what we find in our assessment, we may need to adjust exercise intensity and consider more frequent rest breaks and modifying positions if there's abdominal discomfort or GERD. And really being flexible about scheduling around symptoms because a lot of the digestive disorders have sort of up and down. And so if you can be flexible and schedule when they're having a good day, that might be of benefit. We're going to alert the PT or the patient's physician when there is a sudden onset of severe abdominal pain. That could be acute pancreatitis, sudden onset. Vomiting during or after treatment, that's never good. Signs of dehydration, significant changes in symptoms, unusual fatigue or weakness beyond their baseline, any GI bleeding or fever with abdominal symptoms. So those are all red flags when to alert. So the most important points for us is to know the signs and symptoms of acute GI conditions that require immediate medical attention, and understand when to modify or discontinue treatment based on the patient's presentation, and know how to communicate your concerns to the supervising PT or the physician. For the patient, really taking care of the patient and designing treatment sessions, you need to consider how the GI conditions are going to affect their exercise tolerance, their nutrition, and their overall function. So we, of course, are going to stay within the scope of our practice while providing appropriate support and modifications. So our main role is monitoring and modifications, the M&M. And the common conditions that you'll see a lot, people are obviously not coming into PT for these, but they're coming into PT with these. GERD, peptic ulcer disease, chronic pancreatitis. Usually if they have acute pancreatitis, they're in the hospital, but you might be seeing them there. Inflammatory bowel disease, either type, or appendicitis. And the emergency signs that we really look at are severe abdominal pain, like doubled over abdominal pain.